I was having abdominal pain. I thought it was a gallbladder attack, so I went to the ER, and they did a routine CBC on me and found that my blood counts were lower than normal. So I had to follow up with my primary, and I kept getting blood drawn. They were still abnormal. So I did a bone marrow biopsy, and that's how they found the myelodysplastic syndrome.
But there's one interesting glitch with leukemia that I think you're aware of. For years, people were afraid that leukemic cells would be infiltrating the ovary, which would mean you couldn't transplant it back. Now we know with data from Denmark that that's very uncommon. That because the eggs are located in this dense fibrous tissue, it's really not common at all to have cancer cells in that ovarian tissue. And we'll check very, very, very carefully for that. But nonetheless, there is that risk with leukemia that you, or myelodysplasia, that you don't have with other cancers. And so we're also going to freeze your immature eggs at the same time. But we can retrieve the immature eggs, which we'll do, and then it's technical, but we'll just remove half of the outer supporting cells, cumulus cells, which will allow us to safely freeze them, but will also allow us to mature them in vivo or in vitro at a later date. Before actually doing the ovarian cortex freeze for leukemia patients, we aspirate all the germinal vesicle follicles in order to freeze these germinal vesicles in case there might be leukemic infiltrates in the ovarian cortex. Quite remarkably, the histology of the ovarian cortex for leukemia patients also rarely will show a leukemic infiltrate because of the fact that the cortex is such dense fibrous material. So despite the fears that there might be leukemic infiltrates, as there is, for example, in the seminiferous tubules of the testicles in males with leukemia, in females, histochemistry as well as histology will rarely show leukemic infiltrates. We expose both ovaries through a tiny little mini-lap using a Mobius retractor, which is really not much more invasive than a laparoscopy. And first, we aspirate GV oocytes from the antral follicles of the contralateral ovary, which is not going to be removed. The reason for this is some cancers will metastasize to the ovary, and we'll have to be able to do GV maturation in the future to be able to get them pregnant. Then the remaining ovary on the other side is removed in toto, and then aspiration of the GV oocytes from the remaining ovary on the bench in vitro is performed, so that we have a lot of GV oocytes aspirated from both ovaries, and one of the ovaries has actually been removed. Now, in order to freeze GV oocytes, you have to remove half of the cumulus cells so that the vitrification solution can adequately penetrate the egg. And then the freezing is no different than we do for normal oocytes and embryos using the cryotop method developed by Koyama. Now, the reason we save half of the cumulus cells is so that in vitro maturation can be performed at a later date. And note that in order to have the fastest possible lowering of temperature, it's critical not to have a droplet, but to aspirate all extra fluid away from the egg before freezing. Thawing has to be even more rapid than freezing, at the same time that all the GV oocytes are being vitrified. We begin to resect thin 1 millimeter slices of ovarian cortex in preparation for ovarian cortex vitrification, which is a different technique. We use a special cryotissue microtome type device, which makes it very easy to get slices that are uniformly 1 millimeter in thickness, which is necessary for rapid penetration of the cryoprotectant and for rapid temperature drop of the ovarian tissue at 23,000 degrees centigrade per minute. If you look at fresh human tissue pre-freeze and then compare it to post-freeze tissue, you find absolutely no difference and no damage caused by the vitrification process. We continue now to go through the entire cortex and find as many as 10 to 20 pieces of cortical tissue that we are now preparing in equilibrium solution, which is 7.5% DMSO and 7.5% ethylene glycol, and then place it in the vitrification solution that is 40% cryoprotectant, and wait until all of the pieces of tissue drop to the bottom of the test tube. Now that we know that all of the vitrification media is completely penetrated throughout the tissue, we place it on a copper grid and allow all the extra fluid to come off, and then, avoiding the Leidenfrost effect, we were able to dump it immediately into liquid nitrogen for rapid freeze at 23,000 degrees per minute. And then it is placed in closed storage using a Kitazato cryotissue closed storage system.